All right, let's dive straight in. Welcome to today's Explainer, where we're going to explore the incredibly razor-thin margins of decision-making in critical care endocrinology. We're talking about the adrenal and pituitary axes. Now, these are the body's ultimate survival regulators, right? When they fail, the patient crashes hard, and a single diagnostic misstep here can literally lead to catastrophic hemodynamic collapse. So today, we're going to break down the exact structural and metabolic pathways you absolutely need to master to spot the signal through all the noise and ultimately rescue these patients.
So here's our clinical roadmap for today's Explainer. We'll start with the zona glomerulosa barrier, then we'll move anatomically up to the brain for sellar crater trauma, dive into the lateralization wall, and finally close out with a crucial executional pearl, the metabolic acidosis shift.
Okay, Section 1. The zona glomerulosa barrier, primary versus secondary adrenal insufficiency.
Picture this. You're evaluating a really acute, hypotensive patient, and their morning cortisol comes back dangerously low. Right away, we face this foundational 50-50 dilemma. Is it primary adrenal insufficiency, also known as Addison's disease, or is it secondary adrenal insufficiency? In primary AI, we're usually looking at autoimmune adrenalitis. This is an attack that totally obliterates the entire adrenal cortex, including that crucial outer layer, the zona glomerulosa. On the flip side, secondary AI is caused by pituitary failure. The adrenal gland itself is completely intact, but that activating ACTH signal from the brain, it's just gone.
So, what's the diagnostic tipping point here? When you've got an unstable patient, you're flooded with a massive amount of data. A mild eosinophilia on a complete blood count. That's just noise. Ignore it. The true signal of primary adrenal insufficiency is refractory hypotension paired with severe hyperkalemia, hyponatremia, and volume depletion. And why is that? Well, because the zona glomerulosa is gone, which means aldosterone is completely lost. And without aldosterone, the kidneys just dump sodium and desperately hold on to potassium.
The dividing line becomes crystal clear when you look at the lab kinetics. In secondary AI, the pituitary isn't making ACTH, so your cortisol is low. But here is the kicker. The renin-angiotensin-aldosterone system, or the RAAS axis, remains perfectly intact. Because of that, aldosterone synthesis is preserved, meaning your potassium kinetics remain totally normal. Plus, in primary AI, the pituitary is desperately trying to stimulate those failing adrenals, pumping out excess pro-opiomelanocortin, which breaks down into ACTH and melanocyte-stimulating hormone, or MSH. That MSH drives hyperpigmentation of the skin and mucosa, but in secondary AI, ACTH and MSH are low, so the skin looks completely unaffected.
Now, when you're managing this emergency, the absolute most common and frankly deadly mistake is delaying glucocorticoid resuscitation just to run a cosintropin stimulation test. If you suspect an adrenal crisis, you have to deliver dexamethasone instantly. The beautiful thing about dexamethasone is that it doesn't cross-react with serum cortisol assays. That means you can aggressively treat the life-threatening crisis while still running your diagnostic tests at the exact same time.
Moving right along, Section 2. Sellar crater trauma, pituitary apoplexy versus aneurysmal subarachnoid hemorrhage.
So we are moving anatomically up to the brain now to compare two truly terrifying causes of a catastrophic thunderclap headache. Both of these emergencies present with that classic intense thunderclap headache. Patients will literally tell you it's the worst headache of their entire life. They'll have meningismus and an altered sensorium. But structurally, they are completely different beasts. An aneurysmal SAH is a macrovascular bleed, often from a ruptured berry aneurysm. Pituitary apoplexy, on the other hand, is a sudden infarction or hemorrhage of a pituitary adenoma.
How do you tell them apart in the moment? The tipping point is hyperacute endocrine and structural collapse. Pituitary apoplexy causes this rapid, explosive expansion inside the sella turcica. This acutely compresses the optic chiasm, giving the patient superior bitemporal hemianopsia, which is basically sudden tunnel vision. It also compresses the lateral cavernous sinus, causing an oculomotor nerve palsy, which you'll see as a blown pupil. But honestly, the immediate metabolic killer isn't the compression itself. It's the sudden massive loss of ACTH that throws the patient straight into vasoplegic shock.
Because of this, you absolutely have to follow a mandatory clinical sequence. If you treat an apoplexy patient with standard SAH protocols like nimodipine and ignore the endocrine axis, the patient is going to crash. The endocrine rescue absolutely must precede the scalpel. Step 1 is immediate stress dose intravenous hydrocortisone to reverse that vasoplegic shock. Only after you've secured hemodynamic stability do you even think about moving to step 2, which is surgical decompression.
All right, Section 3, the lateralization wall, uncal adenoma versus bilateral hyperplasia.
Let's shift gears into the dynamics of hyperaldosteronism. You're evaluating a younger patient with persistent hypertension, hypokalemia, and metabolic alkalosis. Their labs show elevated aldosterone and suppressed plasma renin activity. You order a scan and boom, there it is, a solitary 1.2 centimeter adrenal nodule. The immediate temptation here is visual bias. You see the mass, you assume it's a unilateral aldosterone-producing adenoma, basically Conn syndrome, and you just want to cut it out. But rushing straight to a unilateral adrenalectomy, based solely on that scan, is a huge mistake. Why? Well, because in patients over 35, incidental, non-functioning adrenal adenomas, what we call incidentalomas, are incredibly prevalent. You could easily end up removing a perfectly benign, non-functioning tumor while the actual disease continues to rage in the background.
And this brings us to the ultimate medical maxim for primary hyperaldosteronism. Execute adrenal vein sampling to prove functional lateralization. You literally have to go in and physically measure the hormone output from both adrenal veins to prove which gland is actually the one overproducing aldosterone. This adrenal vein sampling, or AVS, dictates your entire game plan. If the AVS shows a unilateral spike in aldosterone, okay, it's Conn syndrome and surgical resection is your cure. But what if the aldosterone gradient is totally equal bilaterally? Well, that nodule you saw in the MRI is just an incidentaloma. The true diagnosis is bilateral adrenal hyperplasia. Surgery isn't going to fix this. You have to pivot entirely to medical management, specifically using an aldosterone receptor antagonist like spironolactone or eplerenone.
Which leads us perfectly into Section 4, our executional pearl, the metabolic acidosis shift.
Let's wrap up with a quick masterclass on the hidden aftermath of that medical management we just talked about. You've diagnosed bilateral hyperplasia, you've started spironolactone, awesome! But look at the precise cellular mechanism happening in the cortical collecting duct. When you use spironolactone to block mineralocorticoid receptors, yes, you stop the sodium reabsorption driving the hypertension. But you also impair the hydrogen ATPase pumps and the principal cell potassium excretion. You are fundamentally altering the tubular ion flux. Failing to monitor for this specific ion shift is a massive execution gap, and it can precipitate a type 4 renal tubular acidosis. Because those kidneys can't efficiently excrete hydrogen or potassium anymore, the patient develops a progressive normal anion gap metabolic acidosis, paired with hyperkalemia. It's subtle, but it's incredibly dangerous, especially if your patient has any underlying heart failure or renal impairment.
So what is the fix here? If your patient develops this type 4 RTA on spironolactone, you've got to step in and balance that tubular ion flux. You basically have two choices: either reduce the dose of the aldosterone antagonist or introduce a loop diuretic. That loop diuretic will force the necessary diuresis, wash out that excess potassium, and restore their acid-base balance, keeping them safe while still keeping their blood pressure under control.
We have covered a massive amount of ground today, from the zona glomerulosa barrier and pituitary apoplexy, all the way to adrenal vein sampling and the subtle dangers of a type 4 RTA. So I want to leave you with this final provocative thought. In the total chaos of an endocrine emergency, can you spot the true signal through all the noise before that tipping point turns into an absolute disaster? These razor-thin margins of decision-making are exactly what separate a brilliant save from a catastrophic collapse. Thanks so much for joining me on this explainer, and keep auditing those clinical pathways. I'll see you next time.